Let's see. So we have another, so yeah, so all the case stock assignment, it's 50 points. So if you are hoping for all 50, you want to make sure you give thorough answers and not just short summary answers that you assume I know what you're talking about, because I'm also a dental hygienist, but because a lot of that is acting like you're talking to the patient, going through a treatment plan. So you want to give thorough answers. So the last exam before the final is neurologic disorders. So everything that we talked about last week. This week's content, autoimmune and HIV and oral health. Autoimmune is hard because you'll see when we get there, there's like a lot, like a swath of, maybe 10 autoimmune conditions, and there's a lot of information on one slide on that condition. But there's literally like 100 different autoimmune diseases. So I'm just giving you guys a taste of like what's out there and what you could see. But that it will be tested on. So you really want to pay attention to that when you're studying, pay attention to that PowerPoint when you stay for the exam. And then the last one is pregnancy and some hormone topics sort of in with that, women's health, hormones, and then oral facial clefts. So those are the last. So it's 1, 2, 3, 4, 5 topics for the final exam, which is a little bit better than the last exam, I think. I would say the last one you had a lot more. So that's going to be week 14. We'll have exam 3, and then the case assignment is also due so that I can read them and grade them over Thanksgiving, because that sounds fun. So that's what I decided to give myself, but it actually will be fine. I'd rather have that time to grade them. So that's why they're due. And I didn't want you guys working on them over Thanksgiving. I want it done, and then you can enjoy your Thanksgiving week. So that's why I made it that way. So those are just some reminders. So then we'll go back up here and we'll go over this. So this one I'm going to breeze through because I feel like we touched on HIV pretty well in pharmacology. So I really feel like this is review. So, the content will be on the exam, but I feel like we've hit a lot of these topics for this PowerPoint before. So we're just going to review HIV and AIDS, the process, the route of transmission and exposure. We'll touch on drug therapy. I'm not on the final exam, like maybe the word like protease inhibitor, non-nucleic, like the heart or the art/heart treatment might be words that you need to know what I'm talking about, but I'm not going to make you memorize a specific drug for HIV. So there's some verbiage around it, like some maybe categories that you need to know, but you don't need to know like very specific HIV drugs. We're going to talk about the relationship in general between like oral health and HIV. It's kind of encapsulated between the fact that they're immunosuppressed in general. And then we're just going to talk about care for the patients, the healthcare team approach to treating HIV patient, and then the risk, the overall risk of treating somebody who has HIV, or potentially if it's seroconverted and they have AIDS. So HIV was first reported to the CDC in 1981 when they were first discovered it and trying to figure out what it was. Essentially, in a nutshell, it was considered an opportunistic illness, and it kind of manifested as like a series of just system functions that were like failing because it attacked the immune system. So it just took them a while to like figure out what was going on. HIV is what causes AIDS, or the acquired immunodeficiency syndrome, and it just gradually impairs the immune system. But really nowadays, like in this day and age, most people that have it, it can be considered like just a chronic condition that's treated with medication. So it can really almost be seen in a similar light as to how they chronically will maintain diabetes, like type 2 diabetes or something like that. Like you can, if you're under good care and you generally keep yourself healthy, it's not the death sentence at all that it was in the 80s and 90s. So just some figures. I checked this last night and it's basically the same. So I didn't change the slides, but there's roughly 1.2 million people with HIV in the US. About 87 out of 100 people knew their status. They knew like kind of where their health was and if their viral levels were enough to, like pass it along or if they were suppressed. And so they were virally suppressed. So they just sort of overall knew their HIV status. 76 out of 100 people received some kind of HIV care. 54 out of 100 people were retained in care. So they're kind of ongoing care. And then this number, I think, is probably the most interesting / important of all the numbers here. 65 out of 100 people were virally suppressed. So that means like they really can't even like transmit HIV to somebody else. The viral load is so small. It's still nothing to mess around with, but that's the good news. They can really be suppressed. The virus can be suppressed in someone's system. So, and then 72% of all people with HIV rated themselves as generally having like good overall health. So in general, HIV, it decreases like our natural immune system. And so pretty much everything that becomes an issue for somebody with HIV, or if it turns into AIDS, is because their immune system is so incredibly compromised. So lots of opportunistic infections. And that's what we see in the oral cavity is we see candidiasis or, all of these things that are really sort of byproducts of other conditions. So opportunistic infections. Kaposi sarcoma, definitely on exams coming up. It's on it's probably on the exam number 3. I think it's even touched on again on the final. So knowing that Kaposi sarcoma is a kind of a specialized type of cancer that we see most predominantly in the population with HIV or AIDS. I mean, I think it potentially could be seen in other populations, but that's where we see it the most often. So how does HIV hijack the immune system? So this sort of encapsulates it in a nutshell, but the virus attaches to a white blood cell that's not able to kill the virus. So it hitches a ride, and that you guys need to also know that it's the CD4 T lymphocyte cell. So that's also like I usually ask an exam question on that. So what type of cell it is. But so it hitches a ride on a CD4 cell. It's not a cytotoxic cell, so it can't kill the virus. And the HIV virion is able to sort of like dump its RNA material into this immune cell. And then it uses that reverse transcriptase to convert the viral RNA to DNA. And once it's DNA, now it can really incorporate itself into the host DNA. So it just sort of gets its foot in the door, takes over, and then it can manufacture its own little factory inside of the human to produce more HIV viruses. So once DNA is established, it can integrate into the host cell's genome. Now HIV can circulate and infect other cells. The virus suppresses host immune response. So there's even less chance that the individual could fight anything off because the whole point of the disease is to fight the immune system or to hijack the immune system. So you guys probably remember this from pharmacology, the HIV life cycle. The reason I like this so much is because not only does it give you like the little picture of the HIV virion attaching to the CD4 cell, dumping off its RNA, reverse transcriptase, getting into DNA, the whole little process, and it has the nice little like this is the binding, this is the fusion, this is the reverse transcriptase. So it just encapsulates the process really nicely. So you can go through and read all those points, but then it adds where the different medications interact. So just like when we're looking at the renal, what's it called? The RAS system of the kidneys, where it's like the angiotensin, blocker happens here. So it can't make angiotensin 1 or 2. Like you can see that flow chart and where the medication actually works to affect the change. So that's why I like this so much. So the fusion inhibitor is one medication. Nucleic reverse transcriptase inhibitors or non-nucleic reverse transcriptase inhibitors. So those are different drugs. And then down here, the one that I feel like most people have heard the word protease inhibitors, because like during COVID, remember Paxlovid is a protease inhibitor. So it just, I feel like that people heard that maybe out in the world or on the nightly news or whatever. So just kind of being aware of these general categories. Okay, so to transmit HIV, it has to be transmitted through specific body fluids. You can't get it by shaking or hugging, shaking hands or hugging. And so it can only be the transmission can only happen from blood, semen, rectal fluid, vaginal fluid, or breast milk. So those are the fluids, the body fluids that would carry the HIV virus. So if somebody did get infected by an HIV virus, what they would feel is within the first, month to month and a half, they would just feel like they got a really bad flu. Like so fever, lymphadenopathy, headache, rash, pharyngitis, malaise, arthralgia. So you just feel pretty crappy and you'd probably go to the doctor because it'd probably linger and you'd be like, what is going on? So for the therapy initially the therapy was pretty horrible. There was some drugs that literally I think killed people, like patients, like the medicine was killing the patients, because they just, didn't really understand what was happening. And then they also were giving just like one drug at a time, and it was causing that drug resistance. So the virus would learn how to evade the drug and then the drug wouldn't work anymore. So there was a lot of problems in the beginning, but through, the decades and more testing and research, now they've dialed it in really quite well. So it's kind of a cocktail of multiple drugs that people have to take. We were just calling it this HAART, HAART, the highly active antiretroviral therapy, but I think they've shortened it to just ART. So antiretroviral therapy is, I think, but you might see it written both ways. But that's basically just a cocktail of drugs is that therapy. So three main stages you can think of HIV, that acute infection where it's in the first, days to month and a half or so of exposure to the virus, and you just have that very acute flu, body aches, like just something's not right kind of response. And that would usually happen initially within the first 2 to 4 weeks. And then you go into that clinical latency. So then that's when, hopefully the person would know that they have HIV, they're HIV positive, and then they would start a suppression medication to just kind of treat the virus, suppress the virus. And because at that point, it's just kind of a chronic infection that you're trying to maintain. And then if it's not well maintained, or if there's, I don't know, something else happening in the person's body that makes them just not handle the virus as well, then it could convert to AIDS, the acquired immunodeficiency syndrome. But most people, I think they can keep them from that stage now with the medication. So the continuation of care is really important for someone with HIV. And this just kind of highlights basically what it involves, which is obviously diagnosing. You have to know you have it in order to not spread it and to suppress it, suppress the viral load. And then so then you got to get linked into good health care, good caregivers that specialize in HIV care, be engaged or retained in care if it's an individual that's just like a part of society, they have a job, they want to have a family one day and just go on living, they're probably easier to retain into care as opposed to someone that maybe is struggling with a drug addiction, or someone who is experiencing houselessness, doesn't have a home. And so the people like that are going to struggle far more with staying on the regimen, having access to the healthcare providers, and taking their anti-retroviral therapy and achieving viral suppression. So this continuum is super important to keep people on that path. So oral manifestations, lots of lovely pictures here. We have HPV, we have Candida, we have Candida, hairy leukoplakia, lymphadenopathy, just all different ulcerations. So a lot of herpetic lesions. So just a lot of opportunistic infections and other viruses that can take hold. So the next couple slides kind of highlighting. So oral manifestations, it's super important to do a thorough EOIO, just like we do with everybody, but also you would want to talk to your patient about doing a self exam on a regular basis, since so much stuff could pop up in their mouth. So they should get used to stretching out their cheeks and looking back as far as they can and sticking out their tongue and looking around. So the first priority if someone has an active infection would be to relieve pain and treat the infection, and then modify whatever risk factors, whatever's going on to try to get them back to sort of a healthier state, and then implement good oral hygiene instructions and try to prevent further infections. And that kind of follows our logic for most everything that we treat our patients that way. So dry mouth, salivary dysfunction, you guys at this point has seen this a bunch. You should know this kind of statement by heart, but 40% of HIV patients do experience some kind of xerostomia. So that's a number that we might not have specifically talked about. Salivary gland enlargement or some kind of disease affecting their salivary glands, and that could be a side effect of medications, most likely. A lot of the HIV drugs, and also if they're taking additional medications like antidepressant, anti-anxiety medication, those kinds of drugs will also cause dry mouth. So of course they have a higher risk factor for caries, and then all the things that we talk to patients about. And this can get trivial, and I know we say it a lot in this class, but these different treatments are really important to really get familiar with. There are so many medications and different ways of handling dry mouth. And so really sometimes like taking a whole class on treating dry mouth can sound like really boring. Like I'm going to sit there for an hour and a half or 2 hours and just talk about dry mouth. But you'd be surprised how much in depth and the things that you can learn and then the products that you can learn about. So it's actually really worth your while. But just to summarize, we talked about artificial saliva, different hydration, things like sleeping with a humidifier, ice chips, sipping on water. I actually listened to a holistic dentist, and she was saying how, dry mouth can be such a problem. And in general, we drink too much. Like we drink too much, obviously sugary drinks like our coffees and our teas and like everything that we just love, but also the water, because, our saliva is supposed to be like high quality and we're supposed to have a lot of it and it protects our teeth, it protects our mucosa. And if you're constantly drinking water, you're sort of diluting some of the good. But if you can't just say don't drink water, because if they have dry mouth, they need something. But that's why sometimes you want to kind of see a bigger picture, and also find out like why they have the dry mouth and find out other things that maybe you can use to help them. Avoiding alcohol and tobacco, that's kind of a no-brainer. And then oral candidiasis would be another really big one. That's a huge opportunistic infection. There's different kinds of candidiasis, pseudomembranous, which is kind of the white yellow plaque, and when you remove it, it's real red and angry looking underneath, so it kind of comes off. There's the erythematous candidiasis, which just in general looks very red and irritated and sort of denuded, of the papilla and things like that. There's atrophic candidiasis and hyperplastic candidiasis, so they're just going to present differently. But in general, once somebody gets a diagnosis for it, if it's just topical, like in the mouth, thrush or something like that, they'll probably use like a lozenge. There could be like a rinse. But if they're have HIV that's affecting their immune system, like actively, they're probably going to put them on some kind of a systemic antifungal, like a diflucan or something like that. Aphthous ulcers are another thing that they could experience at a higher degree. Painful sores under the tongue, buccal mucosa inside of the lip. There's over-the-counter creams and prescription mouthwashes with steroids, or they could take some kind of a systemic steroid. Herpetic lesions, herpes simplex, blisters, sores, that could be on the hard palate, the gingiva, the lips, and they would probably be on a course of acyclovir or Valtrex, something like that, some kind of medication for herpes. Oral hairy leukoplakia, that is the thick asymmetrical white lesion generally seen on the lateral border of the tongue. And I guess it shows up very frequently after an Epstein-Barr virus infection, which, of course, any virus, they're just going to be more susceptible to the different viruses. Kind of like a finger-like or corrugated presentation, and it's seen almost exclusively in the HIV/AIDS patient population. And treatment would be maybe they haven't been on their antiviral therapy. Maybe they haven't been taking their heart therapy regularly, and then that was a cause of it. So maybe if they get back on, then the hope is that that would rectify itself. So here's the Kaposi sarcoma. It's a malignant, really slow growing endothelial cell neoplasm. So it's a part of like a cancer of like blood vessels. And that's why it has this purpley, dark, weird appearance. Mostly in the mouth, it would be seen on like the hard palate. And then it can be seen in other areas of the body. Painless, purplish, brownish, red nodules, primarily on the skin of the extremities, but can also be seen intraorally. And this again would probably be if they're not well controlled, maybe if they're like not on consistent care. So they could end up having to have some kind of chemotherapy to treat the cancer, but hopefully if they had more consistent care, you wouldn't actually end up seeing it in the first place. So the next two slides, this one and then the next one, this one kind of repeats it. But of course, patients that have a severely suppressed immune system are going to be way more likely to have more severe periodontal disease. And so really bad periodontal disease goes into this category of we used to call it ANUG or NUG or NUP. So necrotizing ulcerative periodontitis or necrotizing ulcerative gingivitis. And that's like on another level because you just have sort of like the tissue just sort of like dying actively. It's not just really inflamed and sort of like, reducing the surrounding periodontium, but the tissue itself is sort of dying or becoming necrotic. So for the NUP, they would experience like a lot of pain that, sometimes people with periodontal disease, they're not uncomfortable until you start getting in there and cleaning, and then they're like, ow, that hurts. But they're not necessarily like complaining always about pain. I mean, they probably have an awareness that something's not right. Things probably don't feel healthy in their mouth. But for NUP, they would have a deep pain, bad odor, easy bleeding, teeth would be loose as the bone degrades, and it is associated with severe immune suppressant. So somebody would have to be treated sort of holistically and localized. So hopefully they would have, more active treatment with the overall HIV status. But then to treat the periodontal disease, we'd need periotherapy, some kind of systemic antibiotics, potentially chlorhexidine rinses, although there is conflicting data about chlorhexidine and its effect on like fibroblasts and collagen formation and things like that. But that's kind of an old standard to say chlorhexidine. So it certainly could still be prescribed. Good oral hygiene, definitive scaling and root planing, careful monitoring. And then this is just sort of summarizing like the difference between periodontitis and gingivitis. Gingivitis is just going to be severe marginal gingival inflammation, loss of that sharp papillary edge, as you get more blunting, as there's the necrosis of the tissue. And then that sort of can be compared against this linear gingival erythema. So it's almost like you still have that same intense redness, but you don't have the necrotic piece of it. But all of it is an overreaction to the the bacteria and because the immune system is not functioning. So that needs to be addressed, and then the localized factors and good oral hygiene. So other manifestations, squamous cell carcinoma is the most common type of oral cancer at 90%. So that could, I feel like that's a test question. That just sounds like it could be a good test question. Diagnosed by biopsy, obviously always consulting with a physician. Whenever any patient, I mean, that's just a given. Whenever any patient's medical status seems like far more severe, connecting with the physician or the specialist is like totally warranted, always a good thing. And then HPV, we've been hearing a lot more about HPV lately, especially in combination with speaking to our patients about whether or not they've been vaccinated and things like that. So usually the HPV and oral wart would present itself as sort of a pinkish or whitish, kind of depends. I've seen both cauliflower looking lesion, and it can appear in various areas. I remember I was cleaning it was like a teenage boy, it was like 17 or, thereabouts at when I worked at a general practice, and he had one on his, like, the triangular papilla, like somewhere around his premolars. And at first I was like, what is that? I was like, there's a strange growth on his gingiva. And then the doctor came over and he kind of mumbled wart. And I was like, and this was like probably 10 years ago. And the topic wasn't as talked about. I mean, now I think I would be like, oh, I know what that is. But then I looked at it, I was like, yes, that's what I remember, like from oral pathology. And I hadn't seen it very often. But it was like on the facial of his papilla, but it was definitely cauliflower-like. But then here's a picture of one on palate. So it can manifest in different areas. Okay, so process of care, professional, thorough investigation of health history to establish the HIV positive patient. So hopefully people would be feel comfortable enough to disclose if they're HIV positive or negative. But our general way that we go about infection control is we assume everyone has an infectious disease. And so if you assume everyone has an infectious disease, you treat everybody the same, and your precautions should be at a high enough level that you're protecting yourself and others. But hopefully people would disclose that. But really, it does take some building of trust and building rapport, which you guys are really good at. You're learning those skills of how to build rapport, confidentiality, and importance of gathering all sensitive information. And then these are just some categories. So like I said, we're not going to go into the specific names of drugs within the categories, but just recognizing if you see nucleic reverse transcriptase, that should give it away. If you see reverse transcriptase, that should give it away for an HIV drug. Protease inhibitors can be used for other categories, like we talked about Paxlovid and things like that. But just those are words that should kind of generally put up a flag, like, oh, I think those are treatments for HIV and integrase inhibitors. So again, some more with the process of care. Patients that have HIV or I've only seen HIV positive patients. I don't believe I've actually ever treated a person with full-blown AIDS, but I could have and just didn't know it. But nowadays, it's probably even more less likely than when I first started. But there still can be a social stigma. Most people are well aware now that it's fine, and especially if somebody's under treatment. But building that rapport with the patient, they might feel still off-put to come in and see a healthcare provider, nervous about how people might perceive them. But once you have them as a patient, build trust, build rapport, you can shake their hand, treat them like any other patient, and then they will say, oh, this is fine, everything's normal. And you also realize that you don't have to be nervous to treat them either. And that helps everybody feel better about it. And then it diffuses the unwarranted fears and alienation. So the dental hygiene care plan really, for a person living with HIV, should really not be any different. If they're taking their medications, even if they're virally suppressed or even if they just have a low viral load and they overall seem healthy, there's really nothing different. I mean, really, most patients you wouldn't even necessarily know. It's really when their immune system starts to act a little haywire is when a lot of those issues would creep up. So if they're well maintained, just like somebody with diabetes, if they're well maintained, you're not necessarily going to do anything drastically different. And educate your patient on the importance of good oral hygiene, prevention, checking for oral manifestation of drugs. That's probably the biggest thing would be the side effects of drugs that they might be on, because they're certainly going to be on a high number of drugs. And some of those drugs over time can be really hard on their organs. So they might end up with other chronic conditions 20 years down the line because of some medication they've been taking for 20 years to suppress the HIV virus. Gives patients a sense of control over their disease, encourage HIV/AIDS patients to take responsibility over their oral health. And again, sharing that oral systemic, the mouth is not separate from the body. Disease in the mouth is going to affect the whole body. And so when you really share that message and help people internalize it and understand it, then we're doing our job well. So often, yeah, so treatment plan is not really going to be anything that much different. If you're working like, oh my gosh, I'm so bad with the last names of our part-time faculty. Coulier, Peyton, Professor Quayar. Don't tell her I said that. Quayar. Quayar. Oh my God. It's hard. It's hard sometimes. It's hard being me. Okay. So she works for Russell Street, and I do believe they see a lot of patients there that are HIV positive or AIDS. Am I right? Am I wrong? I'm right, right? Okay, yeah. She'd be a fabulous one to talk to. Don't tell her I messed up her last name. But she would be, because that's who she probably sees a large population there. So I should probably have her come in and do a guest lecture for this whole thing. Maybe next year I'll do that. Okay, so what else does this slide say? So more, obviously if you do see a patient that is having more health problems, there's going to be like a higher order of, care. Maybe the physician will be part of it, that you'll consult more with the dentist, especially if there's, maybe more uncontrolled periodontal disease, or we're getting into one of these other situations where there's other manifestations of opportunistic infections. But in general, that you're not going to expect too much difference between somebody living with HIV and your other patients. So couple stars here. SRP ultrasonic is fine. We all freaked out about aerosols during COVID. And, since saliva is one of the modes of transmission, that can be like, is it okay to use an ultrasonic? And yes, studies, have shown we're safe there. We use our evacuation systems. You can always, have your face shield, use your high vac and things like that. But aerosols are not a mode of the infection. So it's not, wait a minute. Did I say saliva was one of them? It's not, right? No, it's not. Why did I even say that? I don't know why I said it. I made it up. So scratch that. And so I guess maybe I was thinking if there was like blood in the saliva. Maybe that's what I was thinking of. I don't know why I said that. But yeah, so in as much, you don't have to worry about that at all. But because aerosols are just not going to be one way to transmit. Infection control, same for all patients. We treat all patients like they have an infectious disease. Patient with HIV and AIDS present with the same needs as somebody that doesn't have HIV. And then the risk to the health worker. So people are always interested in this. I researched this last night to see if there was an update. And I think this came from a study that they did, and I just don't think they've redone the study. So this is outdated information, but it also was at a time when people were more there was more virus in their systems. So there was a study that went from I put it 85 to 2013. So the Center of Disease Control looked for confirmed times when a healthcare worker contracted HIV through their healthcare working procedures between 85 and 2013, 1985 and 2013, and there was only 58 confirmed. There were a few others that were like suspected, but they weren't specifically confirmed. And then they just haven't, like, I was like, is there more updated? You know, that was like 13 years ago or 12 years ago. Is there something, but I think it's just they haven't run those numbers. And it's fair to say people are less virally there's less viral load in general. So the number is very low, 0.3% to healthcare workers. Another source said 0.2 to 0.3, so well below 0.5% is the risk, even if some kind of an exposure does happen. And then we always follow our best practices, our infection control, and yada, yada. And that's it. So I'm gonna have us take a little break here because I want to print out the quiz. I'm going to do the quiz on the autoimmune diseases, and then we'll go to that next PowerPoint here in just a second. So I'm going to pause. And so we're going to get going here and finish up with autoimmune diseases. So this one is arguably a little bit harder because there's conditions here that we don't think about on a regular basis. I mean, I don't think about them on a regular basis. And so they're easy to it's almost like a little bit of like, I feel like it's like a little oral path mixed in with a little chronic disease mixed in with a little, so this is a little harder. I feel like there's not a ton of slides here, but it's like one slide-ish for the different autoimmune conditions. What's easy about autoimmune conditions is a lot of times there's not necessarily gobs and gobs of different medications. There's a lot of, immune suppressants, steroid medication, and then, dealing with different symptoms maybe. But there's not, so there's not a ton to learn on that end. And of course, those are all going to lead to similar things. Like if you are suppressing the immune system, the patient's going to have more chance to have, opportunistic infection. Like it kind of ties in with what we've already been talking about. So there's some stuff that's sort of easy, it'll come to you, but some of the specific oral manifestations of some of these autoimmune conditions are very specific and very unique. That's where kind of the challenge comes in. And there's like in depth, like we could go on about these different autoimmune conditions in much greater length. So it's kind of, shortened, which is good, I suppose, because we can't go on and on about it. But at the same time, there's a lot more to think about, really. Okay, so we're going to just talk about what is immune dysfunction and the pathophysiology of immune diseases. What? Oh, yeah, sorry. What? I looked at Kelly at first. Like, what am I missing? What?
Just because I know you mentioned that we're not going to go real notes, but I know that like each week it says like we're responsible for studying for the boards. So like
yes, that's a good question.
As far as the boards, like how hard heavy are they on?
So just like with anything, the board is certainly subject to ask questions about things that we might like a drug we didn't even ever talk about. Like I've had I've had students come back and say, there were a few drugs that I don't even know what they, which is just the way it is, because it's like content from across the country, and some programs might have hit one thing and other programs hit something else. And so they basically take what they consider the most common stuff, and some things might be tester questions, like they're just testing the content. So you certainly, could get a question on scleroderma or something like that. And you might be like, I don't remember us talking about it. Well, we had one slide that mentioned it, but it doesn't go into great depth. But that question's not going to make or break you. It's not going to make you not pass the national board. So I feel like
when you do your national board review, there's going to be some autoimmune conditions that rise to the top, and then there's going to be sort of some overall thought processes about like what's important to know about autoimmune disease, and that's what I would focus on. But surely, what the textbook, like what Darby and Walsh goes into, like on autoimmune, or what the national board review materials, I would pay attention to that. And that might be a little bit more information than what you're getting in just this 130 slide PowerPoint today. So it's kind of a balance. Like, don't kill yourself trying to learn all the autoimmune diseases, but also be aware that I not necessarily have touched on everything in just 130. So it is a hard thing to say, but I always say in general, if you're dedicated to studying and figuring out, as much as you can about every topic, you will absolutely pass the national board. Like,
you can't learn absolutely everything. There's just going to be some things that they'll ask you, like I said, they could ask a question on something we didn't even touch on, just because that randomly can happen. But I do think autoimmune is one of those ones where, because there are so many, I feel like the things that rise to the top about like the types of drugs, the most common rheumatoid arthritis is very common. So it's not necessarily going to be on some of these very obscure autoimmune, I wouldn't think, on the national board. But that's just sort of an educated guess. Long-winded, educated. I have no way of answering questions short. I just don't think that's part of my makeup. Okay, recognize the systemic and oral manifestation of common autoimmune diseases, develop a dental hygiene care plan, deliver dental hygiene services safely and effectively for patients with autoimmune. So what's immune dysfunction? So what's going on? So immunologic tolerance is a term to discriminate. It's when your body can discriminate between one's own antigens, one's own cells, and then something that's non-self. So we're made up of tons of bacteria and microbes, and we're not trying to constantly kill off all of the quote unquote good bacteria, and the bad bacteria can overrun the good bacteria. And those are like non-human cells that are in us, So, but the body understands a balance, and it obviously has like an intuition about stuff. And so it's not constantly trying to attack things that it doesn't feel are a threat. So this is an immunologic tolerance. It kind of understands this balance. And then autoimmunity, when innate mechanisms that normally prevent the immune system from attacking self antigens fail. So when your immune system essentially turns on yourself. Now, this is such a huge topic. I've listened to people talk about how this doesn't happen like if everything is in order and you're not being bombarded by some strange environmental toxins and you're generally a healthy individual, the body shouldn't just turn on itself. But we've sort of learned to like accept it, like, oh yeah, that's just what happened in this autoimmune condition. My body just decided to start eating itself. Like it's just something that kind of happens, but it feels like that's more of a trigger of something that you've been exposed to. And oftentimes they do say that that is true, but they also always throw in this genetic component. Autoimmune disease is essentially conditions associated with this autoimmunity. When your body, which normally is meant to just sort of prevent invaders and stuff like that, starts to turn onto its own tissue. Okay, so development of autoimmune diseases, two primary factors usually gets blamed. Genetics is usually always a component, and then environmental triggers. And I think that's just the big unknown. It's like, is it some kind of like, is it aspartame? Did you drink too much Diet Coke? People come up with all kinds of wild things, which don't mean that there isn't some truth to it, but like, what is it in the environment? Is it something in the water? Is it some chemical? Is it something in the air? Some plastics, or the too many plastics? There's so many environmental things that kind of accost us on a regular basis. And some people could just live through life with it not affecting them, and somebody else it could affect them. But it's hard to pin that kind of thing down. It's just really hard to pin it down. There's also shows autoimmune conditions can spike after certain infections, viral infections. So Epstein-Barr and Coxsackie virus can show certain autoimmune diseases. It would be interesting after this swath of time between 2020 and 2023, or it would be interesting 10, 20 years from now if they can see data track some kind of autoimmune conditions that happened after we had the introduction of COVID-19, and to see if there's any kind of autoimmune conditions that arise out of that. Possible trauma, severe trauma, fever, infection, possible medications are thought to also trigger autoimmune diseases. So common characteristics: cluster disorders presenting with more than one autoimmune disease, multi-system organ involvement. Sometimes it's hard to pinpoint because people could have just their whole body just feels crappy, or something. It's hard. It can be hard to pinpoint. General signs and symptoms that tend to overlap with a lot of autoimmune diseases are fatigue, joint pain, muscle aches, sleep disorders, anemia, psychiatric difficulties that certainly could be stemming from them just not feeling good. Like if you can't sleep and your body aches and you're exhausted and like all this depression and anxiety can certainly follow that. There's more than 100 different types of autoimmune diseases, so that's challenging. Getting a definitive diagnosis for lupus or something like that sometimes can take a while. So for the drug categories, just because I'm trying to distill it to sort of some larger thoughts, and not necessarily have you memorize a ton of things. So the first slide here, in general, anti-inflammatory agents, that's kind of the broad category. And we're looking at the salicylates, the aspirin, things like that. NSAIDs, your ibuprofens, your naproxens, Totolac, different, then there's other ones too. Your COX-2 inhibitors, those are types of NSAIDs. Celebrex is a COX-2 inhibitor. And then in general, for stronger, and ones that aren't really associated with pain reduction, the other ones are also anti-analgesics or analgesics, anti-analgesics, I don't know, analgesics. The corticosteroids like prednisone or prednisolone, those are all major anti-inflammatory agents, especially the corticosteroids. Those ones are the heavy hitters. The second one, and I emphasize this word because when it comes up on an exam, there's so many people are I don't remember that word. But this disease modifying anti-rheumatic drugs, it's kind of like a large category of drugs that you can see underneath other things fall into. So if I say, what large category of drugs does cyclosporin fall into? Well, yes, cyclosporin is an immune suppressant. So that would be one thing. If you saw immune suppressant on a multiple choice, you'd be like, oh, it's an immune suppressant. But it also falls under this broad category of DMARDs, the disease modifying anti-rheumatic drugs, blah, blah, blah. So at just that point, I just really want to stress to you, and that's why there's a star there. So of this list of medications, the ones that I really would want you to sort of go, oh, I recognize that. That's why I've bolded methotrexate, cyclosporin, these anti-malarial, the chloroquine and hydrochloroquine. They're anti-malarial, but they're also very commonly used in rheumatoid arthritis. So those are just some ones that I would want you to be able to sort of, we've talked about those in other units. And so they're ones that I would just want you guys to kind of star and think about in your head. Okay, so complications with chronic use of corticosteroid medication. So a lot of times someone with any autoimmune condition is going to take a corticosteroid, and chronic use, high dose corticosteroid they're like a miracle drug when you need to get the body to stop being inflamed. But long-term use is not great. It has all kinds of issues such as insomnia, peptic ulcers, so stomach ulcers, osteoporosis, so, weakening of the bones, cataract formation, glaucoma. It could suppress growth if a child has to take a high dose of it, delayed wound healing, psychosis, that sounds bad, weight gain, adrenal insufficiency, and adrenal crisis. So it's sort of like your adrenal gland produces, like the steroid. And if you're constantly taking a heavy dose of a steroid, you're sort of telling your adrenal gland, we don't need this. You don't have to do your job. So then it's less reactive when a crisis occurs and when you need that hormone or that chemical. So oral side effects of medications. So especially for this one is going to highlight a couple different ones, but mostly we talk about the steroids and the like the NSAIDs. So numerous oral side effects for drug therapy. Comprehensive pharmacological history is important to find out exactly what they're taking. We know all of the anti-inflammatory like pain meds tend to cause adverse bleeding events. So there could be more bruising, gastrointestinal hemorrhaging. They could bleed easier just in the gingiva. Lesions may occur in the oral mucosa. So they could have petechiae or like a hematoma or some kind of blue blackish pigmentation. And then the immunosuppressive drugs can cause gingival enlargement and opportunistic infection. So there's lots of things that can happen for somebody that has an autoimmune condition isn't on a lot of these drugs. So for the dental hygiene care planning, depends on the autoimmune disease or their diagnosis. But in general, the same thing applies. Manage stress, manage pain, manage patient comfort, finding out what they need. Do they need a pillow? Do they need to not be set back quite as far? Do they need a shorter appointment? Do they need to get up for breaks? Just finding out what their needs are, consulting a physician if they have something that you're just not familiar with, or if it's something that's like a bigger deal that you feel like it's going to interfere with your appointment more. And then unusual oral complaints or manifestations. So everybody's unique and might not have the same responses. And then consider the medications, just like what we've just been talking about, the corticosteroids, the blood thinners. Do they need an antibiotic pre-med, and then immunosuppressant drugs? So all those are like your main things that you want to focus on and think about, and know what the big, so when you're studying for the national board, be familiar with those drugs, because those drugs in broad categories, like you don't have to know every drug in there, but in general, if someone's taking immunosuppressants, how does that adversely affect their oral health? If somebody's taking a large dose of corticosteroids for long term, how could that adversely affect their oral health? So those are the kinds of things you want to study for and be prepared for, not necessarily know every drug under those categories. Sorry. Examples of autoimmune diseases. So this is what we're going to go over today, just like two slides for each one of these. Addison's disease, chronic fatigue syndrome, and fibromyalgia, because those are really quite popular makes it sound like you'd want it, but it's like there's quite a few people that have chronic fatigue or fibromyalgia. They're I can't think of the word except for popular, but that's not what I mean. Most common. What a wonderful way to say it. Yes, common. It's a relatively common thing. I think more people have it than some of the other ones, perhaps. Cicatricial pemphigoid. I always feel like I say that wrong. Hyper and hypothyroidism. I actually don't cover hyperthyroidism. I don't believe in this, so I don't know why it's there. I should probably take it out, but I do think we touch on hypo again. Myasthenia gravis. I've had several patients with myasthenia gravis, pemphigus vulgaris, pernicious anemia, psoriasis, rheumatoid arthritis, scleroderma, Sjogren's syndrome, which can also manifest from other things. So Sjogren's syndrome can, like someone with MS could also have Sjogren's. And then systemic lupus erythematosus. So those are the ones we're just going to touch on. They are not the only autoimmune conditions, obviously, but we're just going to touch on those just to give you a taste of what is out there and what can present in the mouth. So Addison's disease, insufficient steroid production by the adrenal gland. So symptoms include anorexia, muscle weakness, lethargy, dehydration, and hypoglycemia. So it can affect glycemic, blood sugar, skin and mucosal pigmentation. So patients can show up with this hyperpigmentation on their gingiva and in other areas in their skin. Important to maintain a stress-free. So if their adrenal gland is not functioning well, we just don't want that the body to demand a high amount of neurotransmitters or hormones or chemicals that are going to try to manage stress, because they don't have that ability. So stressful environment is not good. So pain management and comfort and that sort of thing. Consult the physician for any steroidal pre-medication that the patient might need. And that's really all that we're talking about for Addison's disease. I do add in little additions on the side, but I don't usually draw from that for an exam at all. And then the quiz that I handed out, because it's I put in the PowerPoint and it generates it. And I read through the question and I'm like, do I like that question? And some of them I don't love, but I just leave it anyways. I think sometimes it pulls information from the notes. So if you are having a hard time finding the answer on the PowerPoint itself, it could be in the notes section, I think, just for the activity quizzes that I give you. Not for the exams that I make up for the exams. Okay, second one, Cushing's syndrome. Again, another one related to corticosteroid, long-term high-dose corticosteroid. Hypercortisolism is another word for Cushing's disease. And this can be there can also be tumors involved. There can be other reasons that Cushing's syndrome develops. But one reason can be extended corticosteroid therapy may cause the syndrome. So that's just one way it can develop. Cushing disease, it's also excess adrenocorticotropic hormone production by the pituitary gland. So that's another thing that can happen. And I don't know if it's in the notes or if I just read it somewhere that sometimes it can also involve the growth of a tumor on the pituitary gland. But normally what is seen is weight gain, hypertension, bone fractures, so weakening of the bone, heart issues, poor wound healing, or poor healing in general. Fat accumulates in certain areas. So it tends to accumulate in the face and then on the back of the neck. Or the back of the upper back. And these are medical terms that I just feel like they're kind of not the nicest sounding, but they've been in the textbooks forever, but that's what they called them. I feel like textbooks are probably not going to say it. They just don't sound kind, but they've been in the medical books. So, and I suppose it could be on a national board. They ask you about, what condition can develop what's called a buffalo hump, but it's a fat accumulation up there. And then again, it's really important for the patients to be stress-free. Another very common thing are these striations. If you look this condition up, there's these striations that can happen too. It just shows what the body, when the body's chemicals are out of balance, there's just a whole bunch of havoc that the body can wreak on itself, when the chemicals and the hormones and everything are out of balance. Okay, so consult the physician. If you have somebody with Cushing's disease, this is a perfect time to do more research, ask doctor, call a doctor and ask about what precautions you might need. Okay, so the next one, chronic fatigue syndrome. It's also called myalgia encephalomyelitis. Mostly I feel like chronic fatigue is what most people hear. This is a very hard to treat long-lasting illness. The mental and physical exertion can be difficult. People tire very easily. My neighbor had it. And she just had good days and bad days, and she could only exert herself for a short amount of time, and then she'd just go back to bed. I mean, and she had a lot of migraines on top of that. And she just had a lot of, it's hard to thrive. It's hard to, want to go and do when you just constantly feel mentally and physically drained. Pain as well, usually like kind of pain in all different areas. Orthostatic intolerance, finding it hard to stand. They could get dizzy easily, trouble thinking or severe tiredness, and no known cure or approved treatment. But I do think they're always working on stuff. I should have probably double checked that to see if anything new popped up, because that statement was last year. And I check a lot of these every year because I'm like, I don't know what's new in fibromyalgia or what's new in chronic fatigue, because sometimes they've made some interesting, breakthroughs. Fibromyalgia is another one that's similar. So for oral manifestations for this one, TMJ can be quite not popular. Why do I want to say popular? Common. It can be quite common, just because, again, with fibromyalgia, there's a lot of joints can be affected. So TMJ can be affected, pain in the head and the face, xerostomia. So dental hygiene interventions referred to the physician for evaluation. If the patient complains to you about these things, you get in a conversation and they mention other things, it's well within your purview to say, have you ever thought of, seeing if you can have some further testing to see if maybe you have fibromyalgia, if you have these, other areas in your life that are causing you trouble. And then you also have these oral manifestations. And then those interventions just fall in line with what we recommend with dry mouth, or consulting a specialist if their TMJ is really a problem. So here's one that we're not probably, as maybe you touched on this in oral pathology, but the syncotricial or cicatricial, or I'm not sure even how to say it, pemphigoid. So that one is vesicles or bullae that rupture. So little rupturing, what do you call it? I am so bad with my words this morning, and I have this headache right here. And that's what I'm going to blame it on. I'm like having a headache right here. So I'm like, maybe that's why I can't think of any words this morning. But like a blister. That's what I was trying to think of, the word blister. So like little vesicles, and they rupture, leaving large areas that are sort of ulcerated or denuded. And they'll get that throughout the whole inside of in different areas. It kind of moves around. Lesions are very painful. They can persist for weeks or months. So they might have it, and then, things kind of die down, quiet down, and then they come back up again. So dental hygiene interventions for this one, physicians consult if difficulty with speaking or breathing, like if it's, really bad. They're probably not going to come in for a cleaning, but they might, if they first start developing these signs and symptoms, that's probably the first place you would go as a dentist. Like, what do I have this? So obviously you'll be in consultation with the dentist. You're not going to find these things, but you might write some of this stuff down, take some intraoral pictures, gather information, and then share it with the dentist. Treat lesions with topical or systemic corticosteroids. That's really common. Sometimes dentists will take a biopsy, send that off, and then they'll prescribe like a corticosteroid treatment, either a rinse or some kind of topical application. Topical pain control for lesions as needed, and protect eyes if ocular involvement. That would just be terrible. Hypothyroidism we've talked about, but it's been a little while, so there's a little more information just to kind of remind you guys, because we haven't talked about this since the beginning of Pharm, so it's been a while. But some things that can manifest for hypothyroidism, and some of the stuff we might not even mention when we reviewed it for pharmacology, but mild tremors in the tongue, osteoporosis in bone, axial and peripheral skeleton. So osteoporosis if things aren't well controlled. If a child is diagnosed with hypothyroidism, there can be more issues: premature loss of deciduous teeth with accelerated tooth eruption, faster development of the jaw. For adults, marked loss of alveolar process, diffuse demineralization of the mandible. So if not well-controlled hypothyroidism. These are issues. Rapidly progressive periodontal disease, if things aren't controlled, and then lingual thyroid tissue appears on the posterior dorsal region of the tongue, below area of the foramen cecum. Now, these are all things that we definitely didn't talk about in pharmacology, and a lot of these things probably are more on the rare side. If somebody has diagnosed hypothyroidism, some of this stuff you probably wouldn't even necessarily even come across. But these are some things that can happen with hypothyroidism, probably prior to diagnosis. For dental hygiene intervention, inspect the thyroid gland, note enlargement, presence of nodules, pain, tenderness upon palpation. Avoid overpalpation of gland. So you don't want to like overly stimulate the gland. So just do your EOIO, feel it, see if you feel like there's, extra squishiness or some nodules or enlargement, but don't kind of go at it forever. More sensitive to pain, required, they might potentially need more anesthesia, but we do also have to limit our vasoconstrictors. So that's kind of a note. You might not be able to add more anesthesia. More sensitive to the catecholamines. So if they are uncontrolled, then you have to avoid that. More tolerant to centrally acting drugs, require higher dose of sedatives and analgesics. Manage stress, anxiety, and infections to minimize risk of thyroid storm and monitor their vitals. And so that's it for so yeah, see, I don't talk about hyper, I just did the hypo. So myasthenia gravis. This one is not super common, but I have had a couple patients in my career who had it. And so it definitely has things that will absolutely, like I can say without a doubt, the one individual with myasthenia gravis, I absolutely had to alter care because of his condition. So it's one that stands out. Like as a hygienist, when you get so used to seeing people with diabetes and heart disease and, oh, I had a stroke 6 months ago, but I'm doing much better. And you kind of like, or they have asthma, but I don't have a lot of, attacks or so you don't poo-poo it or minimalize it, but you do become sort of like a little bit sort of just used to it. So you're like, nothing, not too much different happened today. I had all these patients with all these chronic diseases, but not too much different happened. But when I had my one patient with this condition, I absolutely had to change a bunch of stuff. And so, there's certain things that sort of stick out in your head. So some manifestations, this says oral, but some of the first things that can note is in the face. So this should be like facial oral manifestations, drooping eyelids and double vision. That's some of the first signs that someone can have that they're developing myasthenia gravis. And then muscle weakness in the face, head, and neck. So that also includes throat weakness, which absolutely is going to affect swallowing and how they handle water. So your ultrasonic is going to be probably the biggest thing, how you set them up or how you position them in the chair and how much water you use. That's one of the biggest things that you're probably going to have to alter. Difficulty chewing and swallowing, difficulty wearing dentures, soft palate weakness. It can affect the tone of their voice. They can have like all of a sudden just start to sound very weak in their voice or almost nasally. Impaired lip movement, altered voice, nasal tone. They can all of a sudden have a lot more trouble doing oral hygiene care, feeling like they can access areas, clearing food, all sorts of things. There's a lot of things that can start to change once they have this diagnosis. So for dental hygiene interventions, assist patient with the feel of the oral hygiene aids in the mouth, maybe have them hold a mirror, do that show, tell, do, or tell, show, do, or however I get, what is it?
Tell, show, do.
Tell, show, do it that way. And use hands to support. Yeah, sometimes you literally have to instruct the patient to help support their chewing by moving their mandible. Like they can have that much weakness in their face where they have trouble masticating their food. Possible spontaneous jaw dropping, like their mouth just hangs open because their muscles have just gotten weak and that they don't keep their mouth closed. Watch for risk of aspiration. Contraindicated for ultrasonic and air polisher. It's not 100% contraindicated. It really depends on your patient and the severity. So I started using the ultrasonic with this one patient, and it was just too much trouble. And so I stopped. I was like, let's not use that. And it made it more difficult because he had quite a bit of calculus and he was a more advanced SRP, and I couldn't use my ultrasonic on him. So it was a challenge. But schedule short early morning appointments, use a rubber dam, evacuation, mouth props. I definitely used a mouth prop with that patient. Consider nitrous oxide, oxygen sedation for stress and anxiety reduction, and caution some antibiotics have muscle relaxant properties. So obviously you don't want to cause double duty there, and monitor ease of breathing. And he was on high dose steroids. So he was taking, most patients will be taking a steroid. So that can add some other things to it. So for medical management, for this again is for myasthenia gravis, cholinesterase medications is what they're predominantly going to be on. I'm not going to expect you to memorize the name of, but that's one of the main drugs that they're going to be on, is an cholinesterase. I got to start getting these words into my head again for next semester. But that's the main mechanism of action. Immunosuppressants such as corticosteroids, cyclosporin, those are ones we recognize. Avoidance of contraindicated drugs. Now, when we were in pharmacology, when we hit some like the macrolides, that's a contraindicated drug for somebody that has myasthenia gravis. It's nothing that you're necessarily have to directly concern yourself with because you don't prescribe that, but just knowing that is contraindicated. Magnesium is contraindicated, and local anesthetics with high dose of epinephrine can exacerbate symptoms, so you have to use caution with your epinephrine. And then weakness of oral pharyngeal muscles, weakness, risk of aspiration, difficulty swallowing, totally a thing with this population. Avoid excess water. And then again, there's another caution for the epinephrine. So just a few more. I felt like this, we could kind of hone in, and there's a few more things that would really definitely impact your care. Okay, so moving on to the next one, pemphigus vulgaris. Oral manifestations, superficial ragged erosion, ulceration, haphazard distribution. Again, sometimes these kinds of things take biopsy, trying to figure out what's going on. What does this patient have? They'll likely come to the dentist because they're like, what is happening in my mouth? Most common area, the palate, labial mucosa, buccal mucosa, ventral surface of the tongue, gingiva. And this should probably say biopsy was required, but consultation with a physician for early diagnosis. Monitor patient for long-term effects, and treatments are oftentimes immunosuppressants and corticosteroids. Pernicious anemia, failure of the stomach to produce intrinsic factors, and lack of cobalamin or vitamin B12. So they can't get their vitamin B12, and so it causes other issues. So they'll see the painful red burning tongue, atrophy of the papilla. There could be bleeding gingiva, ulcerations. Their body can't absorb enough B12, so that can be just problematic. Energy too, but in general, that's the main problem. Topical pain control for oral lesions and sore tongue, and then supplementing with it, probably with higher doses. Psoriasis is another one, and I don't know what the exact connection is, but there is some connection between psoriasis and rheumatoid arthritis too, or there's some kind of crossover there, but we kind of separate them. It might be sort of different types of the way that the diseases manifest themselves. But for psoriasis, a lot of times people think about it just the skin. They don't think about oral lesions that might manifest. So just kind of make note of that. Oral manifestations are rare, but they can occur, and they appear as white or red plaques mixed with red and white lesions. Could be pustules, vesicles, or ulcerations, and geographic tongue. So there are some oral presentations. So, and I do think I have an exam question that says which of the following doesn't manifest orally specifically, and people usually pick for psoriasis, but that's not the right answer. So just put a star there. Dental hygiene intervention, consult with the dermatologist as needed if there's oral lesions, and again, topical pain control if the lesions become symptomatic. Rheumatoid arthritis, a lot of issues in the TMJ. We also worry about patients' dexterity, how well they're going to be able to, do their oral hygiene, get around the office, just feel good during the day. Like a lot of times, again, if there's a lot of physical pain or swelling, sometimes it takes them a while to warm up in the morning. There might be limited opening of the mouth, drug-induced gingival bleeding, drug-induced oral mucosal lesions, depending on what they're taking. Regular panos to assess mandibular condyle wear in the TMJ. They may or may not need a soft diet, depends on how severe their rheumatoid arthritis is. For pain and joints, moist heat or ice, but I think it depends on what's going on. And then occlusal appliance, oral hygiene for limited dexterity. That's probably one to highlight, because that would be one where we would really be concerned with what can they do, how well can they do it, how can we help them figure out a better tool like a finger handled toothbrush or something like that. Do they need pre-medication? You have to consider that. Also considering things like bleeding time, platelet function, immunosuppression, all based on different drugs. If they're taking a lot of pain meds, a lot of anti-inflammatories, there could be bleeding issues, so you have to think of that. Pain control for drug-induced oral lesions, with a lot of these patients, shorter appointments. Use supportive devices to maintain patient comfort in the chair. Do they need a neck pillow? Do they need a blanket? Do they need something behind their knees? Just attending to their individual needs. So for the drugs that somebody that has rheumatoid arthritis, they're going to be on these DMARDs. Methotrexate is a big one. Hydrochloroquine is a big one. These ones I'm not as familiar with, but certainly they're drugs that they could be on. There's biologic agents that inhibit the interleukin 6, TNF, tissue necrotic factor, TNF inhibitors. NSAIDs, corticosteroids, so they're going to be on all these different types of drugs, and a lot of them have these downstream effects that we see in the oral cavity, xerostomia. Secondary Sjogren's syndrome increases their caries risk. Immunosuppressants increase risk of infection, maintain strict infection control to evaluate healing before invasive procedures. Corticosteroid may delay wound healing, and methotrexate toxicity may cause oral ulcerations or mucositis. There is some interesting information that I've been reading about povidone iodine and it being really good for mucositis. So hopefully we can get some more information out to you guys about some of the benefits of povidone iodine. Okay, scleroderma. This one, I feel like if you star this, I feel like this is an autoimmune condition that you could certainly get asked about on the national board. It's so unique, and it's another one like myasthenia gravis, but probably even more so because it affects the oral cavity so dramatically. And we just don't go into it a lot, but radiographically, you'll see a lot of changes. It's affecting all the connective tissue, and I used to have pictures. I don't think I have pictures anymore. Why did I take out my pictures? Darn it. I think I have to bolster this slide up a little bit. Next year I will. But limited opening, everything becomes very stiff. The mouth can only open as the disease progresses, a very small amount. So limited opening, lots of changes you could see radiographically, widened PDL space, osseous destruction of the TMJ, the mandible, coronoid process, everything sort of deteriorates. The jaw fractures in the late process of the disease because it's gotten frail and thin. Microstomia, so the opening of the mouth, very, very tight and small. limited opening of the mouth, xerostomia, loss of attachment of gingival mucosa, generalized recession, firm hypermobile tongue, difficulty with speech and swallowing, because it's affecting the connective tissues and everything. Everything just becomes rigid and tight and like goes away. And if you look it up, there's usually like the classic textbook pictures are very frail, thin looking individuals with like a very pinched mouth. Like there's just not a lot of opening. Anterior, there could be an open bite. So some of the therapy in the beginning is like this isometric exercises to try to maintain mobility. So when they first have diagnosis, it's like stretching and opening and stretching and opening. And so there's these exercises to try and like keep everything mobile because they know that they're going to lose that. So you're going to have to augment oral hygiene as the disease progresses, semi-reclined position if intestinal issues arise, nutritional counseling, obviously what they eat in the beginning versus having the disease for 10 years is probably going to change quite a bit. Caries risk, fluorides, remineralization therapy, xylitol, antimicrobial mouth rinses, saliva substitutes as needed. So just dealing with what the symptoms are. But this is one that when you're going to study autoimmune, I'd probably refresh yourself on the name scleroderma and then just some of this basic information. Sjogren's is another one because it affects saliva. So it's, up for grabs for sure. It'd be a good autoimmune condition to ask about on a national board. But with Sjogren's, we're losing anything that is a gland that produces some kind of a secretion is affected. So it can have dry eyes. And of course, the dry mouth is the thing that we're thinking about. So we're going to see more redness in the oral mucosa. If the tissue is dry, it's more fragile, more red, more irritated. Enlarged salivary glands, especially the parotid glands, severe dry mouth, difficulty swallowing, all because of, if you don't have enough saliva, we have altered taste, difficulty wearing dentures, fissured tongue, atrophy of the papilla. You're going to be more susceptible to candida, obviously to caries, periodontal disease, all from a lack of saliva. Because saliva just is like our liquid that gives us all of this stuff, gives us so much stuff that benefits our oral cavity. Systemic lupus erythematous, or SLE, oral manifestations, only about 5 to 25% of patients will have oral lesions with lupus. Locations of the lesions could be palate, buccal mucosa, gingiva. They may appear as a lichenoid, so like a white or a plaque-like. They may look nonspecific or granulomatous, whatever that means. Ulcerations, pain, erythema, hyperkeratosis. So this kind of thick, white, keratinized look to them. Xerostomia can also be a problem. And so then we have all the downstream effects of xerostomia there. Dental hygiene interventions, just have to question whether or not premedication is needed. For that question, you're just going to have to ask the dentist or a physician. Antifungal therapy. So a lot of times these interventions are like, well, what do they have over here? And so sometimes, just to give you another way of looking at some of these things, you don't always have to remember lupus, possible antifungal. It's like dry mouth, possible antifungal, right? I mean, so it's like you can take some of these things that are just constantly repeated and then just remember what can happen downstream from those things. Because you notice a lot of this stuff is in direct proportion to if there's ulcerations, dry mouth, that's uncomfortable, that's open tissue for more bacteria. And so now how can we heal that? How can we make the patient feel more comfortable? How can we prevent opportunistic infections? So that's sometimes an easier way for your brain to critically think about these as opposed to like trying to memorize bullet points. And it also is better for my brain to process it. Okay, I think this is the last one. Chronic cutaneous lupus erythematous. So again, lesions. We're talking about some lesions, erosive lichen planus. So just raw red areas in the mouth. Refer again, a lot of times these are biopsied. They may be referred to a dermatologist for a definitive diagnosis. Patient education, obviously, if they have lesions that are painful, they're not going to want to eat spicy foods. Avoid acidity or spicy foods, and then helping them think maybe this doesn't say it here, but maybe a bicarbonate mouthwash, or maybe potentially even something for a mouthwash instead of like a Listerine or chlorhexidine or one of these other ones that we use, maybe a biotine or maybe even a diluted povidone iodine, and something that they can rinse with to kill bacteria, but that's more gentle on the tissue. So as always, thorough health, oral, and pharmaceutical histories, prioritize their oral and medical needs. So what's going on in their mouth? What's the stability of their condition? You might need to consult with a physician. May aid in the diagnosis of an autoimmune disorder. If an oral thing pops up first, they will come to the dentist. What's going on? And it's not like things like that are usually diagnosed first off. Sometimes it's a long process to get a definitive diagnosis. And oftentimes referrals are definitely part of it. So some final thoughts in general, no matter who's in your chair and what you have in front of you, you always want to minimize infection and restore health, and then educate the patient about the role of bacteria and all of these things, whatever is their specific situation. Patients must understand the relationship between the condition, medical management, and oral care. Is a specialist needed? Is an oral pathologist needed? Do they have to have a biopsy? Do you have to send them back to their physician for different medications? Or, to say this medication that they're on is causing a major problem here. So sometimes you have to send them back and try to figure out, I'll just say that the patient or the church member that plays the piano, the lady I've told you guys about that had a liver transplant. Do you remember I told you she had cancer, squamous cell carcinoma, because that's a high side effect of someone with who's had a liver transplant. But she was on a medication for a couple of years, wrecked her GI, wrecked. She's 77 pounds. She came in every time we sing once a month, and she plays the piano, and I do song service with a couple other people once a month. And every time she comes back, she is a walking skeleton, and it breaks my heart. And she has found out that it was a side effect of the medication. It's absolutely wrecked her GI. But I feel like some other things have now happened. But she said last week, this past weekend, that she's 77 pounds. It's awful. So just to end on a happy note, but just to let you guys know, like sometimes the medications, like they might not be able to stop the medications, but maybe you'll see something and say, have you ever thought it's your medication? Maybe you should go back to your doctor. And so sometimes we can just be a voice to kind of help our patients think about those things. Encourage them to do the oral self-examination. A lot of times, if they have an autoimmune condition, they're going to have to be in at a more frequent recall, maybe 3 months, maybe less, but maybe 4 or 5. Everybody's going to be different. And then, as always, you're going to document and see how things are progressing with your patient. But that's that. I know that was a ton. Sorry, I felt like that was like a marathon of information.